So today's speaker is Dr. Parang Sanghavi. He's a consultant radiologist at Picture This by Jhankaria, and he's done his MBBS. He has done his radiology training from the prestigious KEM hospital in Mumbai. After that, he did a one-year fellowship in chest and musculoskeletal imaging. He has received multiple awards across various platforms, be it IRIA, RSNA, and his special interest is in chest, and he's also a part of the Society of Chest Interventions and Chest Radiology in India, who has recently come up with guidelines regarding COVID, how to manage, is imaging really necessary, what imaging features are important, and other things pertaining to COVID, because imaging has been used discriminately all over India. So he's part of the core team who came up with the guidelines. He's also interested in swimming, cycling, and enjoys traveling. Unfortunately, I don't know how much of that is possible right now, but I'm sure once everything goes down, he would love to travel to various parts of the world. With that, I would like Parang to take over and start his presentation.
Hi, Amar, and thank you so much for the kind introduction. I hope I am visible and well audible.
You are.
Okay, so I'll just start sharing the screen. Right, my screen is visible, right? Okay, so thank you so much, Amar, for this kind introduction and also for this invitation for this exclusive talk on COVID-19. And we have come already a long way. It's already been more than 1 or 1.5 years since we know COVID. And even in India, if you see, it's more than 1 year that we are already dealing with it. And now with the second wave, we have also realized that no matter how much we already know, there is also something new that keeps coming. And this disease is actually, keeps changing or keeps coming up with new things. And with this superimposed complication that we are now seeing, virtually epidemic over epidemic over a pandemic is something very serious. So if you see this image, it started with just coronavirus, and then we have CT coming in big way last year. We know these findings, and now this is something that you see on the right side that we are going to discuss actually mainly today. So over a period of next, we'll try to finish in 40 to 45 minutes, that we'll just briefly see these HRCT manifestations and signs and mimics and differentials that I feel is very important, because earlier what used to be that how to pick up COVID-19, now it is more important when to call it not, because not every ground glass or every consolidation in the lungs is COVID. Of course, our index of suspicion is very high in current times, no matter why the chest is being screened for. But still, we should be aware that there are other diseases out there, and especially when there are definite signs, we should not call it COVID-19. So that's why mimics and differential is something that I really like to focus on. Then we'll again just briefly see the CORADS and CT Severity Score with some important points that what you should be focusing on, because there are some errors with respect to that also that is happening. But our main talk is going to be on the recent advances or the recent stuff that is going around. That's mainly vasculopathy and the dual NGCT, the role of DECT. Then, of course, the follow-ups, fibrosis and quantification is very important, because as those who have come out of this disease are going to land up in some form of complication, or if there is a fibrosis, they will need a long-term follow-up and treatment for that as well. And finally, of course, the mucormycosis, the black fungus that we all are now hearing almost on a daily basis, even more than COVID-19 now. So just to briefly see, this is all we all are aware. And moment we see this, anybody can actually, even the non-radiologist, even a non-doctor person can now diagnose COVID-19 looking something like this. But just to get the idea that COVID-19 typically present in this manner, where we see bilaterals, almost symmetrical ground glass opacities, and the perivascular is the key word, that it shows the perivascular distribution, and usually there is a lower lobe predominance. And this is a very stereotypical COVID-19 where you should not be even thinking twice. Then what is crazy paving? That's another common manifestation of COVID-19 is when this ground glass attenuation in over and above, you see some septal thickening also. So if you see this ground glass is actually similar to the previous slide, but on top of it, you can make out this some smooth reticular opacities or the septal thickening that is present. So collectively, both of them together gives rise to this something called as crazy paving pattern. Another sign quite specific or quite sensitive for COVID-19, but not specific. Remember that these are all signs that we had already before even COVID-19 came. So that's why some of the differential that we are going to discuss. And there are some literature also suggests that there is a kind of evolution that happens. It starts with, if you see those typical, like this first case, you are pretty much seeing the disease in the first 3 or 4 days. If you see something like this, then it's 4 to 8 days or almost a week. But remember, this can present in any time. It is not deciding factor for that. We have seen the cases presenting on a day one with crazy paving pattern, even with consolidation. So the next pattern is consolidation, and typically people suggest that if there is a consolidation, it is more to do with severity rather than the temporal evolution or the disease process, that how it evolves. The patient can present directly with consolidation, and yes, these are the patients who usually are not so well and they need oxygen and usually are hospitalized. So yes, the importance of consolidation over and above ground glass is you need to mention this specific finding, whether the lesion that you are looking at are ground glass or consolidation, because this patient are usually not doing well. So the clinician has an idea that this patient might need some hospitalization during the course or can be monitored more closely. So that's the more importance. It's not that the consolidation will not be present in the first 3 or 4 days. And then there are this fancy signs, which are again not specific, but yeah, we do see the halo is something when you have the central hyperdensity or the consolidation surrounded by ground glass. Reverse halo is the other way around, where the ground glass is in center and the consolidation is around it. And this again, reverse halo is also is going to be now a very important sign to pick up mucormycosis, and that we are going to discuss at the end of the talk. But remember, these are not a specific sign that is present in one patient that you can see only one sign. So this patient has more of a consolidation and some ground glass in the lower lobes, while the upper lobe show this reverse ground glass or the atoll sign. So you can have the all combination that can happen in the same patient only. And like I said, the importance of consolidation is, yes, this patient usually have a more severe disease. And now if you're in India, where the patient can actually come by himself or herself without even consultation for a direct CT scan, just because he has heard or seen these images, or he has come into contact with someone who has been now diagnosed with COVID-19, even despite being asymptomatic, he can directly just come for a CT scan. Then you might pick up some early signs. Like we have seen this type of cases also who are asymptomatic completely, but just want to rule out their COVID-19. And yes, then you might see such subtle ground glass lesion, very few of them, maybe just 1 or 2 in the entire lungs, both combined together. And then the way of picking up them better is doing the MINIP reconstruction. If you see the image on your right, what happens with minimum IP or the minimum intensity projection is the background lung kind of become homogeneous, and hence this type of lesion really stands out. So if you see this image, what about this vascular marking? They also look more or less similar to that. But if you see this minimum IP image, then you can make out this lesion really well. So if you want to pick up subtle lesions, or the patient is already diagnosed with PCR positive and has come to CT and you feel that there is nothing, it is a good idea to run a MINIP stack and to rule out if there is no lesion at all for sure. So these were all the signs. What they collectively form is a pattern, which is the organizing pneumonia-like pattern. Remember that disease pathology is not organizing pneumonia, not at histopathological level, but what we see is organizing pneumonia, because pick up this is a very typical COVID-19, right? But haven't you seen this before even December 2019? Of course we have. And that time we used to call it organizing pneumonia very easily. And the patient may have underlying collagen vascular disease or something, which is the cause for this organized pneumonia pattern. So this is which similar to this, what we see in COVID-19. And then eventually they can show reticulation. So reticulation is usually seen in advanced disease or when there is the lesions have start resolving. So the earlier what we saw, the ground glass and consolidation, once they start reabsorbing, they leave lesions like this. So if you see some patient who are presenting with this, you know that the disease is not acute or a recent. This has occurred in past, and these are the resolving lesions. And we are going to see in the coming section also that how the follow-up also helps in these cases. Then there is something called as bands. Again, bands is something that was said to be presenting as a part of resolution or the healing disease, something like this, where you see a linear band-like opacities in the lungs. But remember, they represents the edematous lung overlying the area of hypoperfusion. So even we have seen this type of appearance even present at the presentation in the first 5 days also. And finally, those patients who are really sick and severe, dependent on oxygen, or present like something like a ARDS like clinical situation, then just like any other ARDS of other etiology, they show similar findings with a very diffuse large lesions in both the lungs, especially in the lower lobes. And the upper lobes, we see this typical non-dependent parts sparing, or the anterior parts of the lungs, which is just like any other ARDS when they are not involved. So remember, when you see this also, you know that the patient can have a very serious course of the disease. So this was just to get the briefing about the COVID-19, what all we have seen so far in last 1.5 years, how they are differently presenting. So keeping this in mind, let's try to rule out the mimics and the differential that we may see or the disease entity which present with this similar kind of ground glass and the consolidation. So why these are the differentials? Because they also follow the similar ground glass or the crazy paving or the organized pneumonia pattern or the ARDS AIP like pattern. So this is actually very interesting because this is the first case that we saw in our practice. This was, I think, March second week in 2020, when we just started hearing about COVID coming in India. And I think there was just one recent paper that came from Wuhan which described the CT finding for the first time. And we know that this looks like organizing pneumonia. There will be a ground glass bilateral. And this was the images that I saw, and I immediately got panicked that, okay, this is probably the first case of my or are in Mumbai or in our practice that we are being seen. But clearly, if you now see, there is some difference. Rather than the perivascular type of ground glass, what we see here is the lobar or the consolidation type of a ground glass. We see the lesions across the bronchi and across from periphery to the center going all the way in. Of course, in advanced COVID also, we may see something like this, but this is something unusual. And what the idea of ruling out is to keep in mind that this type of patient may not have COVID, and if at all the PCR is done and it comes negative, you should immediately start thinking of this other etiologies. And if you see the lower lobes also, it shows some kind of a nodular appearance. The nodular densities are very rare or not seen in COVID-19. And this was our first case. We actually called it, raised the suspicion of COVID-19, and then eventually it got worked up and did really well. The patient came out of it really well with the treatment and just a short course of hospitalization. And this is what is the organizing pneumonia. So this image, in fact, this particular case is of course from 2018, if I'm not wrong. And what you see is typical reverse ground glass, what we just discussed, the atoll sign, where you see the central ground glass surrounded by consolidation. And this is something not specific of COVID-19. So if at all, the clinical scenario is not matching with COVID-19, if the patient has underlying collagen vascular disease, then do keep in mind that this is actually the organizing pneumonia and needs further workup. And if there is no underlying etiology, we would then call it as a cryptogenic organizing pneumonia. Then what about this case? Now, this is very, very typical. Now, if something like this comes up, we will immediately call this COVID-19. But this, again, is from 2016. And the patient already was a known case of eosinophilic lung disease. And this is how the typical chronic eosinophilic pneumonia looks like. The peripheral subpleural opacities, there is subpleural sparing also, consolidation. And this is how the typical eosinophilic pneumonia also. So if there is so always keep in mind the clinical scenario. That's what the idea is. The lung actually presents in a very finite pattern, like what we discussed, the consolidation, ground glass, and nodules, etc. are only the 6 and 7 patterns and the various combination of it which decides it. So of course, we are not going to see some different altogether pattern or a new finding that comes up even if there is a new disease. So that's why there is a very fixed findings that we see invariably, no matter what the underlying pathology is. But there are then certain specific signs, and more importantly, putting in the clinical scenario is what is more important to come to a particular diagnosis. If you just look at the images, you will have a 10 differential always. But this is something that I really need to highlight, because this is where the problem is, because the patient can obviously have an underlying ILD that has been there for years and can present with acute exacerbation. And that time you really need to think hard that whether it is an acute exacerbation of the ILD itself, or there is a superimposed COVID-19. Again, a very difficult thing to do, not possible all the time. If you see very specific findings of COVID-19, yes, otherwise in something like this patient actually had an acute exacerbation and was COVID-19 negative. But yeah, in this type of cases, you might end up giving a possibility of COVID-19. But if at all the COVID-19 has come negative, then please give that possibility always in your report that there can be an acute exacerbation of the ILD itself, and the management will change because now the steroid will have a more important role immediately right up front rather than waiting for some time like in COVID treatment. Then IgG4 disease, again, not something that you can directly call it on imaging. But again, if you see something like this, a bronchocentric and the subpleural opacities, who have otherwise some kidney disease or some other underlying etiology that is known like IgG4, other manifestation like a retroperitoneal fibrosis or mediastinal fibrosis or a pseudotumor elsewhere, then you need to keep this in mind. So again, the idea is to always keep the clinical scenario, get all the details ready. The history is very important. The COVID-19 is not something that without history also you can diagnose, because the mimics needs to be really thought about if there is no COVID-19. Then chemotherapy related lung injury can present with organizing pneumonia. Even PCP in HIV. Like, so again, if you don't know the patient is a known immunocompromised or a known case of HIV, you will directly call this or COVID directly. But if you know that there is a patient, there is a history of HIV, you will at least give a thought and give a possibility of PCP, which will help to investigate further on these lines as well, because we know that this is also a typical manifestation of PCP. And of course, the crazy paving word, when you hear, the first thing that comes into mind is the pulmonary alveolar proteinosis, because that's where the first we saw the crazy paving. And again, if you see something like this, very typical across the entire lungs without showing any perivascular distribution or any zonal predominance, and the patient has a typical history of expectoration and bronchoria, and then of course just doing a simple lavage will improve it. Like in this case, post lavage scan was done and shows near 50% resolution of the lesions. And again, the final differential is the pulmonary edema. And again, this is something where giving a COVID-19 differential is not acceptable, because pulmonary edema usually have this specific signs that is most of the time present. So all you need to keep in mind is to look for this always bilateral pleural effusion. Now, again, in COVID-19 itself, just giving it sheer severity or even with a patient with ARDS can show pleural effusion. But if at all there are bilateral pleural effusion, remember, COVID or not, the first thing you need to rule out is pulmonary edema. So anytime you see bilateral pleural effusion, do look for the other sign like ground glass attenuation. Of course, it's not helping you because that's in COVID also. But what is this? The smooth septal thickening. This is not crazy paving. We are not seeing in the interlobular region. These are the septal thickening or the interlobular septal thickening. And when this thing put together along with pleural effusion, and then also you can see the cardiac status, there is a mitral calcification with LA dilatation. Putting all this together, giving a COVID-19 possibility is not acceptable. So this is something where you can directly call this as a pulmonary edema, and there is no need to call COVID-19 or workup for that. And of course, in India, if you see that the patient with old TB or any other infection can suddenly present with hemoptysis, then again, having this history of hemoptysis is very important. Like this particular case was actually reported as a CORADS 4, but COVID-19, and the patient was given isolation for 14 days directly. While he came for a follow-up scan, and this was the previous scan which we reviewed, and we realized the patient had a history of hemoptysis just 2 days prior to the scan. And there was no lesion elsewhere, as you can see here in this representative image that I've shared. And this is the old cavity of the prior TB that's lying there. And this thing was present, which was completely resolved after the follow-up scan. So clearly, this is the intra-alveolar blood, which is seen because of the hemoptysis. And there was no need to call COVID-19 or further workup for that. So these were all the important differential that you should always keep in mind, or the time when it is easy to call that it is not COVID-19 and a specific diagnosis can be given on a CT scan. Of course, there are lots of other possibilities, and then we need not be able to pinpoint it, but always keep in mind the clinical scenario, and the clinical notes has to be present with you all the time before you interpret any CT scan. So giving all this, whenever you see ground glass or consolidation or a crazy paving or organism immunopattern, can you not diagnose COVID-19? No, there is a specific sign of COVID-19, which is angiopathy. So even quite soon in the disease progression, I think in May, the first paper came that described this angiopathy, that it is not actually a pneumonia per se at the cellular level. There is an angiopathy that is going on, and that is what the deciding factor is. So you will see this type of changes that may be present. So when you see that there is a consolidation or the ground glass lesions with such prominent proximal vessel, intralesional or proximal vessels, it doesn't happen in any of the previous differential that we discussed, because the vasculopathy or the angiopathy as a primary issue is seen with COVID-19. So when you see this, yes, your index of suspicion should be very high that this can be COVID-19. And then once this paper came, we started looking for in our scan also, and we could easily see this with this maximum intensity projection also, that the vessels are so large in caliber and going up to the subpleural region also all the way. And then all this paper that started coming in the month of May and June, which of course the fancy sign that they described like Dandelion sign or the feathery sign, and nothing but the appearance where the basic pathology is there's the central abnormal vessel or the dilated arteriole, which then shows surrounding ground glass attenuation. And this is what the basis of vasculopathy was proven, that there is a vasculopathy going on in COVID-19. And then this particular sign, vascular tree in bud, was also described by Patel et al. In 2020. And it is clearly different from the bronchial tree in bud that we see in tuberculosis, where the vessels here itself will show such type of nodular appearance along its wall, which is nothing but a sign of angiopathy. Then this target sign also that came, that also proved that there is a perivascular inflammation, because what happens in this target sign is there is at the center is your vessel, Then there is a perivascular inflammation, which shows this ground glass attenuation. Then surrounding is a relatively spared lung, which do not show any pathology as such. And then again, you see this ground glass halo. So all this happens around this central vessels, which is the cause of the angiopathy in COVID-19. So then how do you further confirm it? How do you confirm any angiopathy? Is by demonstrating the dynamics changes or the perfusion changes in the lungs. Now it is very simple to do that in brain, because we are so used to do this perfusion studies for the patient of stroke or even the masses. But in lung, you need to have the dual energy machine to do this. So when we do this regularly for all our patients for pulmonary thromboembolism to prove the perfusion defects, but even in dual energy CT, it could easily seen. So immediately after that vasculopathy theory that came in, lots of people started doing the research on the dual energy CT, and they could easily see this. If you see these lesions, typical perivascular ground glass lesions show clear hyperemia. There is a reduction in the cerebral, pulmonary perfusion here. While surrounding it, there is a hyperperfusion or a hyperemia that is seen in the lung adjacent to it. No matter wherever you see in the lungs, all the lesion shows hyperemia, with surrounded by hyperperfusion or a hyperemia. And then the multiple papers showed the similar findings. And this interesting paper also that came last year, they did not compare at a lesion level or where the lesion is present. They just showed that if you see the lung in the entirety, the overall there is a paucity of blood vessels. So in healthy individual, you see, if you do the reconstruction and you find the blood vessel volume per cross-sectional area, you see so many vessels. While in the COVID-19 patient, no matter where the lesion are, there is an overall paucity of vessels in the entire bilateral lungs. And that also further reinforces the theory of vasculopathy. And then these were all qualitative studies. And then came the quantification also, that can you do the quantification also, again, with the help of dual energy CT, you can actually measure the PBV, the pulmonary blood volume, just like the cerebral blood volume that we see in the brain perfusion study in the MRI. So similarly, you can pick this up, and clearly it shows that there is a significant drop in the perfusion. If you see, the lesions are present only in the lower lobe, but the entire lung overall shows a reduced perfusion. So then we started looking at many of our cases. Also, we started, of course, the administering contrast just for the sake of COVID-19 is not acceptable. But those patients who were serious enough or where there is a suspicion of thrombosis and were asked to do pulmonary angiography, we started doing this dual energy CT, and we found the similar results in our cases also. There is a clearly hyperperfusion in the lesion surrounded by hyperemia, as seen in this case also. And again, these perfusion defects are not related to thrombosis. If you see, the pulmonary angio is absolutely normal. There is no thrombosis anywhere whatsoever, but still there are perfusion defects because there is a angiopathy that is going on in COVID-19. But remember, there is a high risk of pulmonary thrombosis also in this patient, and it is very frequent. It doesn't occur in the central large vessel like in pulmonary thromboembolism. It occurs in the segmental and self-segmental branches more commonly. So you need to do your angio really well to pick up this small filling defects in the peripheral part of the lung. And it is due to severe lung inflammation and a hypercoagulable state. So it is not thromboembolism per se. The emboli are not coming from leg or elsewhere. They are formed within the lungs because of the pathology or the inflammation and the hypercoagulable state. So then this was our first case where we run that, and we saw that the patient has a background ILD and he has COVID-19 proven, and we could see those ground glass lesions. But on top of it, when the pulmonary angiography study was done, there was this thrombosis found, or there was the filling defect that was seen in the right lower lobe pulmonary artery, and some were in the left also. But when we run this dual energy perfusion maps, we could see that not just there are some perfusion defects in the territory of this thrombused vessels, but even elsewhere there is a significant drop. If you see, there is hardly any perfusion anywhere except in the upper lobes, and that too in the right lung. And this is the time when we really thought that the angiopathy can be very severe in such cases, and to our surprise, the patient actually did so well and actually succumbed to COVID-19 the very next day. So clearly this has an importance in prognostication also when you see such diffuse large perfusion defects in the lungs. Then comes this type of cases. Now remember, this is a very specific sign that should always alert you to look for a thrombosis, is the pulmonary infarct. The lung infarct looks like this. If you see the mediastinal recon window, you can make out this subtle bubble-like lucences, which is very typical of appearance of a pulmonary infarct. And if you can see there are COVID-19 lesions as well, then you should always do a pulmonary angiography and specifically look for the subsegmental branch leading to this area, and you will be more often than not will be able to pick up this small segmental thrombosis. And again, this adds to the prognostication that the patient with COVID-19 with perfusion defects further deteriorates even if there is a thrombosis and the infarct, that will lead to further change in the management also. And again, we tried doing this quantification also, and we also found in our cases of this COVID-19 that yes, there is a significant drop in the pulmonary blood volume or the perfusion. So these are all the signs that we discussed, that on plain CT also you can make out these signs, and when these are present suggestive of angiopathy, yes, your confidence of calling COVID-19 goes very high. And if you have done CT pulmonary angiography or a contrast study, and if you have a dual energy machine, you can find out all these signs as well. So this was all about the COVID-19 manifestation and all, looking at the CT and the contrast studies. Now we'll just briefly see the CORADS is something that actually was developed quite early. It came up in May 2020 directly, and hence we can assume that the pattern was just to initially make everybody primed to calling something COVID-19, that it was a new disease, something new finding. And of course, we don't know how it can present. There are just some signs that were present. So it gives the confidence level. And the initial idea to put from 1 to 6 was to tell that whether you are at all confident, or you are completely confident, or you are somewhere in between. But now with the current times, with very clear science that we discussed, there is no need to actually call with CORADS 1 or 2 especially, because 1 and 2, 1 is something that is where you can actually, 1 or 2 is something that there is practically zero chance of COVID-19 on imaging. And those are time where you have to actually call what you think of it. So 1 can be even just simple, plain and simple lung fibrosis. Like I have seen reports saying there is a post-infectious fibrosis in right upper suggestive of CORADS 1. Now, what sense does this make? What is, because the moment the CORAD word comes on a report, everybody starts thinking of COVID, and somebody can even misinterpret that, okay, there is some chance of COVID-19 at least, even maybe as small as 1%, there is some chance. That's why it is mentioned in the report. So remember, calling CORADS 1 and 2 doesn't make any sense. It is the time where you have to actually say what it is. Like it can be just fibrosis, or 2 is something where you know it is tuberculosis. You see cavitary lesion, you see branching lesion, you see necrotic lymph node. And then you on top, while calling TB, you also call it CORADS 2, doesn't make sense at all. And 5 and 6, 4, 5 and 6 is something where you can say, again, 3 is a bit dicey, but yes, there are some times where you really hit your brain very hard that whether you want to call it COVID or not. That is the time that once in a while you can call it 3, but otherwise by and large only calling 4 and 5 makes sense in your report. Rest all the time you know it is not COVID-19, so might as well tell what it is rather than telling what it is not. And 6 again is when there is a RT-PCR positive. So every time people get a lesions in a known RT-PCR positive, they are happy to call CORADS 6. But the moment there is a normal lungs, again everybody is confused that what to call it. Then again it doesn't make sense to say CORADS 6, because it's not compulsory to write everything in CORADS. You can describe what you mean actually. So the simple and plain way of saying it is, yes, the patient has RT positive, PCR positive status, but there are no lung lesions. It says everything what it has to say. It doesn't mean that you again put CORADS 6 and then make the people wonder that, but where are the lesion to call anything CORADS? Because CORADS is first and foremost a CT scoring, the CT system. So again, it confuses. So remember, 1, 2, and 6 use it in the specific scenario only. Otherwise, try to avoid those terminologies. So this is what 1 can be even normal, but again, calling 1 will confuse it. 2 is something, this is a very typical branching train bird appearance. It's a COVID-19. We know that. Then why to get confused? But this is, yes, something like this. If this is the only lesions in both the lungs, yes, we are not sure. And we don't want to even completely rule out COVID-19. We want the clinician to further work up with PCR test. Then yes, CORADS 3 makes sense. CORADS 4 actually was initially described even for the unilateral lesion, but now in current time, when we know this is a very typical appearance, even if this is the only lesion or present only in one lung, we will directly call this as a CORADS 5 and a definite COVID-19. And of course, this is our typical CORADS 5. So actually, while CORADS became so famous and got accepted everywhere, even by non-radiologists, even the clinician actually demand you to put CORADS. And that's how it got really famous in India. Actually, this RSNA consensus statement that came just around the same time actually makes more sense, because rather than calling those 1, 2, 3, 4 and the typical things, it gives the more meaningful terminology like typical, indeterminate, atypical, or negative. That's what we really mean. It actually says the same finding if you see from 3, 4, 5, and 6. But actually, it gives more meaningful by ruling it out, saying anything like 1 and 2 and then creating confusion. So the same thing, what we saw earlier as 1, we can directly call it negative rather than 1. This is something as atypical, and we need to know the specific diagnosis, which in this case is tuberculosis. This is something indeterminate, and this will both become typical. It becomes so much easier for everybody to understand also, rather than those confusion of 1, 2. So this was the only important part about CT or the CORADS. Rest everything people are really well aware of, and using it for almost a year. Everybody has got really used to it so well. Then same way for CT severity score. Again, using this 5-lobe system or the 25 scoring makes more sense than the complicated per segmental approach and a score of 40. Because first of all, you need to know your anatomy really well, the segmental anatomy really well, to divide anything in segment. And the secondly, you should have that much time. Like in the second wave, then when India got really hit by the second wave last, when I mean pretty much many of the radiologists used to report more than 100 scans a day. Then how can you get into a subsegmental level where it doesn't add any value to the prognosis or the management of the patient? So that's why using this 5 lobes approach, it becomes more easy also, because everybody can easily delineate the 5 lobes in both the lungs rather than those 20 segments. And it also gives the pretty much the same idea by calling it eventually whether it is a mild, moderate, and severe. So again, everybody knows how to calculate, but remember to always use the 3D MPR recon while calling it, because something like this may appear so small on Excel and you might neglect it, while on Sage and Core Recon, you may actually realize that it has got a sufficient volume. So the best way to look at it is to look at it in 3D. And of course, at the end of the day, it's just eyeballing. So of course, it is going to vary with person to person, but overall, by and large, you should be able to come to a definite conclusion whether it is mild, moderate, and severe. So that's why the best way is to, whenever you are calling anything from 8 to 9, do give a hard thought about whether you want to really call anything from mild to moderate, whether you really feel that. And same way when you cross the 15 barrier, which is from moderate to severe, because especially when when the healthcare is overwhelmed, like everywhere in the world, not just India, the moment somebody gets a severity score of 16 and a severe disease, even though he is not that symptomatic, there will be a very, very big issue whether the hospitalization has to be there or not, whether the patient can, suddenly deteriorate. And those are the patients where you would even want to monitor closely. So then that time, be very careful what you are saying. Otherwise, 12 and 14 are not so significantly different, or for that matter, even 18 to 20. Of course, in follow-up, it may matter. But otherwise, try to, when you break that barrier from 8 to 9 while calling from mild to moderate, or from 15 to 16, do give a proper thought that whether you really want to change that category. And this is what, just to give you example, what 25 and 25 looks like when the entire lungs are involved bilaterally completely. And this is the other model that I just told. And of course, it is very complicated. It even asks to divide in 0, 1, 2, less than 50, more than 50. And of course, you need to know your segmented anatomy really well before you can use this. So that actually brings us to this. So again, by now, I think everywhere the CT scan have really gone down. I think part of it because of the awareness also. And that was the need, because last month, I think in March and 2021 and April first week, we realized that there were more than 100 scans being done on every CT scan center across pretty much every state in India. And then we realized that more than half of them are actually walk-in patients, those who have not even seen their clinicians. Just because they have read, they know that lung get affected, lung, you see these findings, and you need that score. You need to know your score really well, as if like it's your SSC or HSC marks, that people really feel that you need to know that. Even people are not so scared just to know that whether they've got COVID or not. They want to know first that how much of the lungs is affected, no matter how their symptoms are. So it's not something that every patient with score of 12 is worse than every patient of score of 9. So at the end, clinical scenario matters, and CT is to add to it, to help in the management, and not to diagnose or prognosticate by itself. And that's what led us to our team. Of course, they involve many, almost everyone is very well versed with the chest imaging, with some of the senior people even having experience more than 20 years. And we decided to come up with a very specific guideline. Now, even if you see the other guidelines, there are certain things which complicate you. But if you read our guidelines, we just kept in mind that we want everybody to understand when to use it and when to not. So yes, we had to include when to do it. And if you see that there are specific situations also, like when patient has to undergo emergency surgery and RT-PCR testing is not available, that is something when no matter of the symptom of the status of the patient, the consultant might want to do CT scan immediately just to get the idea that how we should be managing the surgery. So we have kept those options also open. It's not that we are categorically saying just don't do in any mild cases. We have kept in mind the Indian scenario specifically where there is actually being used. And then there are management and follow-up also. But on top of it, we even came up with non-indication. This is where we actually try to make a difference by telling the patient, if you see there are specific lines saying that if the patient or relative wants or demands to just to see the CT check the status of the lungs. It doesn't make any sense, because like I said, if your SpO2 is 98, 99, you are doing so well, there is no breathlessness. Even if you get a score of 10, it is not going to change the management, or it doesn't require to change the management. Rather, it adds to the apprehension and makes the patient more worrying, and rather he will be then running around in different hospitals thinking that he has at least a moderate disease and not just mild, as what the symptoms otherwise suggest. And then we'll be running for a hospital bed, and that actually led to even the chaos that we had about the hospital admission, the shortage of the bed and the ICU. So actually then I think pretty much around this time when it got published, then we saw some decline, and hopefully it made a difference. And you can easily see this article. It is freely available on the SCI website, the Society of Cardiothoracic Imaging and Intervention. So that was all about the how you should be doing the CT scan. Then it brings us to the follow-up and of the fibrosis and quantification, because as more and more patients, we have seen that everywhere across the world, and even in India, there is a phenomenal recovery rate. More than 90% of the patient just comes out of it without any significant symptomatic wise problem. But we do see that there is a residual fibrosis, and which then eventually lead to a problem. And that's why if you have any AI based software like Caliper that we have, of course, this is a patient with acute COVID, and we see predominantly ground glass. So if you see, it gives the exact quantification that 76% is normal. So saying that is a 24% abnormality, giving a percentage, and predominantly it is formed of ground glass lesions. And of course, there are multiple software by Siemens, and even you can, if you have a OSIRIC software, you can do using Salafi method, and that really helps. So what is the importance of follow-up? That if the patient is symptomatically not following the path as expected, or if there is a further deterioration, then only you need to follow up and then see for the lesions. So typically what we see is on a follow-up scan is most of the patient really comes out without any significant abnormality, and you see more than 90% of the lesions have resolved. Or sometimes you see this, what we discussed earlier, some reticular opacity, what was initially described as a melted sugar or the cotton candy sign. And this is actually really helpful when you see this directly as a presentation of the patient don't have this type of previous scan. Then just keeping in mind this type of appearance helps you that these are nothing but a resolving COVID lesion, and you should not be unnecessarily raising suspicion of active COVID. Most of the patient do come out, but sometimes the patient can have deterioration, and especially if there is a first CT scan is done right at the day of presentation or in the first 2 or 3 days, when invariably we see very mild lesions. If there is a follow-up done without a reason, just like many hospitals have a protocol to do a follow-up scan at every 3, 6, 9, 12 days, then you might end up getting this type of images because the disease is going to show its evolution. But if the patient is doing symptomatically well, then just by knowing that the lesions have increased is actually not going to help and create more troubles. And sometimes it can even happen that some part of the lung, like this right upper lobe lesion, shows improvement, while other part of the lung, which is the left lower lobe in this case, I'm sorry, this shows worsening, while this shows improvement, while this shows new lesions. So this may also can happen, and again, it may not have any significance unless there is a change in the clinical scenario. So when to call it fibrosis, that's another big question. So as of now, actually anything calling post-COVID-19 fibrosis is not safe, because if you have seen the follow-up of the patient, even we have some follow-ups who are more than a year now, whose initial scan was 1 year, you see that the lesions keeps improving no matter what. So even if there may be gross lesions like this, if you do a follow-up, you will see some improvement. So we know that these are not fibrosis, they are just slow healing lesions, and that may eventually even clear off. But still, if you want to call anything post-COVID-19 fibrosis, it should have architectural distortion, honeycombing, or traction bronchiectasis. But again, do advise a follow-up also, even if you are called fibrosis, and that is the time where you can actually decide if there is a no change at all, then it will further reinforce that there is a fibrosis. But otherwise, even some of this part of the lesions may also show resolution. And this is the time where the quantification really helps, because the ground glass quantification is not so important, rather the fibrosis. So if you see this patient has a 42% lung involvement, out of which 17% are the reticular opacities. And that is the time when you know that this patient may need further follow-up for fibrosis as well. So this was about the fibrosis part. Now some of the interesting cases that we just saw. So this was a patient with COVID-19 typical findings, and just while seeing the upper abdomen that we usually cover in CT chest, we saw that there are bilateral adrenal hemorrhages, and the patient did not have any other symptom otherwise except for the chest findings. And we didn't know what is the significance of it, but when we searched, we found that there were some papers who described this bilateral adrenal hemorrhage findings, and this patient again don't do so well. So no matter what is the status of the patient, you have to immediately call up the referring physician and inform that there are bilateral adrenal hemorrhage. And again, this patient also did not do so well and actually succumbed to it in just 2 days time. Then cavitation. Again, many people are still believing that cavitation can occur in COVID-19. It is not the case. Usually, if you see cavitation, you have to think of a superadded infection, which in this case was tuberculosis, and it is not uncommon at all. You will see it in so many cases. Then patient can also have a carcinoma. So this patient again presented because of COVID-19, and the carcinoma was actually a kind of incidental finding. But yes, of course, they can coexist together. And this is something that we already saw, that a patient with pre-existing ILD can have this ground glass, and this can COVID-19 as a superadded complication of the ILD. And even this patient was actually, if you see the lung findings, apart from this typical COVID-19 ground glass lesion, the background high density and calcified lymph nodes actually tells you. And once we found out the occupation, the patient actually had silicosis with COVID-19. And again, another finding is the cystic changes. Again, people want to think that a cystic change can also occur in this. But if you see that some of this patient may have a previous can also, and this is actually nothing but the central lobular emphysema. The patient is a smoker. Then of course, over and above, when you see the ground glass lesion, you will see cystic lesions within them, but it is not actually due to COVID-19. This was emphysema because the patient was a smoker. And the last interesting part about is the axillary lymph nodes. So I hope everybody is at least aware that once you have the COVID-19 vaccination, mRNA, you can have axillary lymph nodes in the ipsilateral arm. So just keep in mind, because this can be a problematic, especially in case of infection like tuberculosis, or especially in a patient who are on a follow-up for known malignancy, whether there is a disease progression or not. And that's why this radiology paper that came out a couple of months back, and they described that there can be lymph nodes can be as large as even 1.5 to 2 centimeters. But first and foremost, there will be a history of vaccination, usually in the past 1 or 2 weeks. Then there will be ipsilateral finding only in the same side where the vaccine was given. And of course, if nothing of this helps, then you need to follow up. Of course, after a period of some time, if you do a follow-up with simple USG, because it's just the axillary region, you can easily follow up with USG, and then it should show follow-up. But otherwise, if there is a serious clinical suspicion of disease progression of a malignancy as well, then sometime there will be no choice but to do a biopsy to confirm. So this was all about COVID-19. And then once just we realized we have seen everything of COVID-19, this something new that came is the black fungus. So even if you don't know anything about fungal infection, mucormycosis, I'm sure by now you were forced to read about it and to know about it. And we have seen like there is actually said to be an epidemic of mucormycosis in India right now. So that's about, now we are going to mainly focus on the mucormycosis or the black fungus. So remember, mucormycosis doesn't mean the mucor fungus per se. It's the family of mucorales. So if you see the kingdom in fungi, there is subtype Mucormycotonia, of which there is a mucorales, and the family is Mucoraceae, of which there is a specific genre which is mucor. So remember, mucor and mucormycosis is not synonymous in that sense, and there are other species also in that. And in fact, if you see, the Rhizopus is rather more common than mucor. But the whole idea or the whole issue of mucormycosis is it is angio-invasive. It can lead to tissue necrosis, and that's why significant mortality and morbidity. And what the types we see, the typical and the most common is the Rhino-ocular-cerebral, that we have already seen so many of them in last couple of weeks. But remember, pulmonary is also very common, and I'm going to show at the end the pulmonary cases also. So do keep an alert to see for the pulmonary mucormycosis as well. And then there can be GIT and cutaneous also. The high risk factor, as we all know, is the uncontrolled diabetes mellitus, and the steroids are the number 1 and number 2 risk factors. So if they are there, and of course COVID-19 adds to it, it's not a high risk factor per se, but it leads to further deterioration in the immunity, and especially with uncontrolled use of steroids, especially early in the disease when it is not required, has actually led to this epidemic in our country. Then of course the transplant, immunotherapy, malignancy, renal failure are of course a high risk factor, just like for any other immunocompromised state. But the other risk factor that you should always keep in mind is the inhalation. Basically the patient who are on oxygen therapy, if the oxygen mask and the tubings are not cleaned properly, then that also adds to the risk factor for this fungal infection. Poor hygiene, especially mask hygiene, hardly people realize that if the mask itself is soaked and not used properly, not thoroughly clean between using again, it has to be air dried and put in sunlight very clearly. The foggy mask can also lead to this mucormycosis. And of course, there is a reason to believe there is a genetic predilection also, because not everyone who is receiving steroids or who have COVID-19 are getting it. So why does in COVID-19, but apart from immunity, if you know early in the disease also, what was called as the cytokine storm was the theory of COVID-19 severity. And immediately people realized that there is an elevated ferritin and interleukin-6 levels, and that were used as a biomarker even for the follow-up of this patient, that how well they are doing. And it is actually this ferritin or the increase in the iron level which is even further helping in the mucormycosis changes. And of course, as we discussed earlier, there's a vasculopathy also. So there is already an endothelial damage that is happening due to COVID-19 itself. Then it will further help for the mucormycosis to cause angio invasion. So this is a simple diagram that there are these risk factors of steroid, diabetes, and COVID-19. And COVID-19 per se specifically lead to increase in interleukin-6, which leads to increase in ferritin and intracellular iron, which is actually helping and further leading to increased number of cases of mucormycosis in our country. So now what about the radiology? So we'll see first the common type that we have seen so far is the Rhino-ocular-cerebral type. So again, MRI with contrast is the investigation of choice. But as we know in our country, it might be difficult to get MRI in every patient. Then CT scan also can help. And in fact, most of the cases we have the CT scan findings also present. But in MRI, we know that one particular sign, which is the black turbinate sign, is very, very sensitive for this. And once you see this, so that's why whenever you do MRI, please ensure that you give contrast, because this is what will help you to pick up this black turbinate or the non-enhancing or the necrose turbinate over and above the finding of the sinusitis. Again, the mucosa will also be non-enhancing in case of mucormycosis. And this is the sign that we will specifically look for when calling something mucormycosis. This is another such example where you see the turbinate is entirely necrosed and non-enhancing. That is the black turbinate sign. And remember, diffusion restriction can also help you. So if you see this case, whenever you are doing the MRI for this purpose, always run the diffusion scan also, and you will see this diffusion restriction also in cases of mucormycosis. But remember, black turbinate is not a specific sign of mucormycosis, or for that matter, any other immunocompromised condition. Black turbinate sign can be seen even in immunocompetent cases, but it shows little difference. So if you see the initial example that I showed, there was the entire turbinate was seeing as a black or the necrosed or a non-enhancing turbinate. Usually this immunocompetent patient who get this black turbinate size will typically involve just the posterior aspect, more even can be bilateral, but this posterior aspect rather than the entire turbinate. You may see such thin internal septation. If you see those black turbinate are the completely jet black turbinate, while you see some internal septation in these cases, and you will see some preserved enhancement. Like in this case also, if you see this is a peripheral thin enhancement that is present rather than the entire black turbinate at what we saw here. There is no peripheral enhancement. The entire or the most of the turbinate is involved. There is no septation delineable within them. Then you know that that's a true black turbinate. But if you see any of this sign, especially in an immunocompetent patient, don't jump to directly mucormycosis unnecessarily. So then comes the CT, because that's actually the workhorse for mucormycosis, because not everybody is getting MRI done. So then you will see a hyperdense soft tissue that can help you to call anything as a fungal infection. But importantly, CT is an excellent modality to look for erosions and osteolysis. So if the disease has progressed enough to cause these changes, then of course the CT will also help you pick up these findings very easily. So let's see some of the typical types that we saw, that we are going to see. So if there is a cerebral or the ocular involvement in addition to the typical nasal sinuses involvement, then you will see an intraorbital soft tissue, thickening of the extraocular muscle, commonly the medial rectus. But of course, it is not that there is any predilection for that, and that I'll show you in examples. There can be optic neuritis, cavernous sinus thrombosis, and when there is a cavernous sinus thrombus, always look for the arterial thrombosis and related infarcts and other intracranial extension. So this is what we typically see in just a rhino-mucormycosis where there is no extension otherwise. What you see here is there's a diffuse sinusitis. There is near complete opacification of all the sinuses except the sphenoid sinus. But on top of it, what you see is the clear erosion osteolysis in all the walls of the maxillary sinus. Even if you see on the left side, there is some involvement of the orbital floor also. And don't forget to even see this area, the maxillary or the palatine process and the alveolar processes. They also start showing erosions very commonly. And once you see them, you know that you are not dealing with simple sinusitis, but there is a invasion or the invasive fungal sinusitis. Similarly, in this example, if you see, there are lots of osteolysis in the floor as well as along the floor of the orbit as well. And then if you see, in addition, what you see here is the intraorbital soft tissue, predominantly in the extracorneal compartment, and which rectus muscle involved here is the inferior rectus. So remember, it's not that the medial rectus has to be present. Like many of the times people always look for a medial rectus involvement or the thickening before calling mucormycosis. Is not the case, because it's a simple common sense. It's the involvement by invasion or the local invasion. So if there's a maxillary sinus disease leading to the floor osteolysis, which further leads to the extension in the orbit, of course, the inferior rectus will be involved first. And that is what we see in this example. As again, there is a ethmoid sinusitis, which is the pathology. Along with, of course, there is a fungal, there is a maxillary involvement also. But this time, the lamina papyracea is completely gone, the medial wall of the orbit, which has led to the intraorbital extension. And then, of course, the nearest rectus muscle is the medial rectus. So now you will see the medial rectus involvement. So remember, it's not that something, a golden rule that the medial rectus has to be involved. It is actually what sinus and what is the path of invasion that the mucormycosis is following. So as we saw earlier, this was the case of floor involvement with inferior rectus. Well, this is a case of medial rectus, then why not the superior rectus? So just in this example, this was the case with frontal sinusitis. If you see, the maxillary sinus are completely clean, but this patient has actually the frontal sinusitis, which has led to thinning and erosions in the roof of the orbit, leading to the invasion of the orbit. And that's why what we now see is the superior rectus involvement. So remember, don't jump to the conclusion if the medial rectus is normal, as in this case, it cannot be mucormycosis, it can still be. Basically, what we are looking for is the sign of invasion. And similarly, this case I recently saw, and of course, we all know that any fungal invasive infection, you have to look for the pterygopalatine fossa, because once the disease has spread to pterygopalatine fossa, we know that it's like a multi-gate chamber, and from there the lesion can extend into multiple pathways intracranially, intraorbitally, in the mouth, in the nose. And that's what had happened here. The patient has a posterior ethmoid sinusitis. You can see some erosions in the walls. And what has happened is, through this sphenopalatine foramen, the disease has directly progressed, even if it is a mild soft tissue. Because of this sphenopalatine foramen, it has extended into the pterygopalatine fossa directly. And this patient is really at a high risk for further intracranial and other extension, and needs to be treated very aggressively and followed up also. So this was initially, first we saw the rhino-mucormycosis, then the ocular part. Now we are going to see the intracerebral extension. And if you see something as gross as this, that the ethmoid sinuses involve the entire anterior cranial fossa floor is showing osteolysis, and which has led to the extension of the soft tissue or the abscess in the frontal lobe. And again, it can show cavernous sinus involvement. And if there is a thrombosis of internal carotid artery, it can even show such large infarcts. So always keep in mind that you need to see all the possible local site of extension and invasion in case of mucormycosis. And if at all required, you have to do additional imaging like MRI or any other test that will require to prove the angio invasion and even this type of complications. This was another example where, because of this right ethmoid sinusitis, has led to direct extension in the middle cranial fossa with nice abscess seen in the temporal lobe. And it actually led to the complete thrombosis of the right internal carotid artery because of direct extension in the cavernous sinus. And the patient also had this complication. So this was all about the rhino-ocular-cerebral mucormycosis. So like we discussed, if you have the option, do MRI with contrast, because that will show every findings row very well. But even if you do CT, and if there are, you have to look for all the walls of all the sinuses to look for any subtle erosions also. The commonest being the lamina papyracea, the floor of the orbit, and the walls of the maxillary sinus with the maxilla itself. Then comes pulmonary mucormycosis. So now since last 1 week or 10 days, I am getting so many referral or so many referred scans who have some atypical findings on the chest CT scan over and above the COVID-19 or the post-COVID-19 sequelae. And what I'm typically seeing is the pulmonary mucormycosis now. So it has, of course, the similar risk factors what we discussed for the rhino-ocular-cerebral, but the radiology findings, it initially starts with as a small perivascular ground glass lesion, which may be very difficult to say as a mucormycosis, but it progresses very fast. So just in the next couple of days or 3 days follow-up, you will see the lesion growing out of proportion. It progresses to large nodules, consolidation, and masses. And the ground glass halo is very much more common and typical in these cases. Sometimes the halo can be larger than the nodule or the lesion itself. Then the reverse halo, remember the reverse halo is a very important sign here. So we have already discussed it can be present in COVID-19. We already know that it can be present in other fungal infection like aspergillosis also. But so far it has been proven to be most commonly associated with pulmonary mucormycosis. So reverse ground glass halo, if you see UAR antenna should really go up. And of course, if there is a cavitation, then also it's likely to be mucormycosis. And then there will be finding of angio invasion and infarct, just like we saw in cerebrum, it can occur same way in the lungs as well. And if you have done MRI, again, not a modality that we will do at least for the lungs, but there is a sign called a T2 hyperintense rim or the black hole sign described with the central non-enhancing area that will help you to specifically say that can be mucormycosis. But remember, mucormycosis is not the invasive fungus. We already know that there is an invasive aspergillosis also. In fact, before this COVID-19, rather the aspergillosis is more common. So then how do you differentiate the two based on the CT scan? It is not always possible, but there are certain signs described which are going to favor mucormycosis over and above aspergillosis. That one is more than 10 nodules. So remember the aspergillosis usually are few lesions, maybe larger, but few lesions. If there is a progression that has led to so many lesions, then it is more likely to be mucormycosis. Reverse halo, like I said, it has shown to be more specific for mucormycosis than even aspergillosis. Presence of pleural effusion, and of course the concurrent sinus infection. If you know the patient already has an invasive rhino-ocular or any type of fungal or mucormycosis there, then you know that the lung findings can also be present. So this is one typical example. If you see there are ground glass lesion or a typical COVID-19 findings, more likely in a resolving stage, like this patient was. And in addition, the patient has started developing this large nodule or the consolidation with central ground glass attenuation. So if you can appreciate, there's a clear reverse ground glass halo. And like I said, no matter what the diagnosis, if there is a clinical suspicion, this is not going to be COVID-19 or aspergillosis, this is more likely to be mucormycosis, and always raise this possibility. And otherwise, other common finding that we now typically see is the presence of cavitation also. So again, if you see there is a large consolidation, there is a background COVID-19 lesion. I hope everybody can appreciate. These are the COVID-19 sequelae, reticular opacities. And you see this large new lesion on the follow-up case in the right lower lobe. And again, you can see that the ground glass is pretty much in the center, and the denser part is at the periphery. So there is a reverse ground glass, and there is a cavitation also. So again, this patient are more likely to have mucormycosis. And again, this patient was proven to be mucormycosis. And this is also a similar looking finding, the reverse halo sign with the cavitation. And in addition, we can see pleural effusion also. And you can see the patient had actually COVID-19 sequelae. There was a bit of fibrosis also because this is present since 8 months. And now the patient has developed mucormycosis. And of course, you have an angio invasion, then leaves no doubt with you, just like in PNS. So same way, this patient has a large consolidation with ground glass. Difficult to appreciate reverse ground glass here, but almost ground glass with cavitation. Very typical findings again with even pleural effusion. But what you see here is the superior segmental branch of the right lower pulmonary artery is completely thrombus. So once you have seen this, you have a proof of angio invasion, and this is a clear-cut case of mucormycosis. And if you see even the right inferior pulmonary vein is started to showing involvement with some irregularity and partial thrombosis. So once you have seen this, all the proof of angio invasion and everything, you need to keep in mind the mucormycosis always. So over a period of last, I think we have almost gone past 50 minutes now. So we tried to see the common HRCT manifestation and signs. With the help of that, we tried to understand how to rule out this mimics and differential. Then we briefly saw about the CORADS and the CT severity score and some important points about it. But then we mainly saw about the vasculopathy and the role of dual NG-CT, the follow-up scans and the when to call it fibrosis and use of quantification methods for follow-up. And finally, we saw the current issue, the epidemic of mucormycosis with respect to both the paranasal sinuses as well as the pulmonary manifestation. So thank you so much for your attention. And I hope, Amar, is that fine? We are, I think, a
Yes.
little over.
No, I think it's fine, Dr. Parag. This was phenomenal. Like I have never heard such a exhaustive talk on any topic, for that matter. There were questions coming in, but as we were going through your talk, you were covering each and every topic in such detail, and I'm sure all our viewers will agree. I would like to request all our viewers to give us feedback. So I see there are around 400 live viewers, but there are only 70 likes on the video. So make sure that you hit the like button to let Dr. Parag know how awesome his talk was. The other thing is that if this will help YouTube send more relevant radiology videos to your feed as well. We'll move to questions. There were quite a few of them, but most of them were answered by you. So there were quite a few questions about follow-up and bands in the resolving phase. So Dr. in the Making and Dr. Sneha Gaikwad have asked questions regarding the resolving phase. So the first question is, can we see bands in the resolving phase? And the relevant question to that was, when do we call fibrosis versus a resolving phase? So if you can answer that, that would be great.
Yeah. So when I was describing that, I already said that bands, yes, they are commonly seen in the follow-up scans, but it doesn't mean that the patient has an inactive or an old COVID-19. It can be seen even at the presentation or even in the first 14 days for that matter. So yes, when you have a follow-up scan and you know that the lesion, which was initially seen as a consolidation and has now started showing improvement with kind of contracture, then it may leave those bands. At that time, you know it's going to be useful for the follow-up, and eventually they all will disappear. So again, the idea is again not to call them fibrosis immediately, because if you see a long-term follow-up, even if there are severe lesions, there are score of more than 16, 20, 24, such diffuse lesions cannot disappear immediately. But we have seen even the patient with 60 or 70% lung involvement, every follow-up after 3 to 6 months shows some improvement. So no matter even after 1 year, there is a significant residual disease, there is still improvement going on. So that's why I said, even so far, we are not in a comfortable position to call anything upfront fibrosis, because you may then see after 3 months, it may also resolving. But yes, if there's an architectural distortion and there is honeycombing, yes, those are the signs which are not going to reverse. But apart from that, just looking at the reticular opacities or a significant residual disease, it's not safe to call. The best idea is to describe them as a reticulation only and ask for a follow-up depending on how more you are seeing improvement. If you have already seen more than 50% improvement, it is again not prudent to follow up just in a couple of months or 3 months. Then the next follow-up should be 6 months. But again, it is driven mainly by the clinical scenario. So your clinician has to be involved, and he is the one who will be actually deciding the next follow-up.
Thank you. And do you recommend low dose non-contrast CTs for all cases? And is there a point where you would suggest contrast given the angiopathy? So what is your protocol? What are you following in terms of contrast and low dose versus normal dose?
So by going by protocol, every CT scan for COVID-19 screening is a plain study, no matter what the situation is. So again, the clinician, if there is mainly the time when there is a clinical, the clinical symptoms are disproportionate to what is expected. And apart from that, as we all know that when the moment somebody is COVID-19, D-dimer are invariably done. So if the D-dimer levels are rising, that is the time when there will be always be a clinical suspicion of suspecting pulmonary thrombosis. So no matter you see a score of 20, 24 or even 25, it's not for us to decide actually. If there is a clinical high suspicion, if there are parameters that suggest there might be thrombosis, that is the only time when you should do a pulmonary angio study.
Excellent. On similar lines, Dr. Saili Joshi has asked, is there a role of thrombolysis in subsegmental thrombi? It's more of a clinical question, but do you have any experience in that?
Yes, those anytime. It's not just for the central disease. The moment there is a diagnosis of pulmonary thrombosis or thromboembolism before this, like even if due to DVT, the first treatment is thrombolysis. The patient undergoes that only, and if there is an improvement with that, then that solves the entire clinical situation with that. So yes, all the subsegmental, it doesn't mean that it is mild, doesn't require. Any thrombosis, any pulmonary thrombosis, just like cerebral, are all invariably treated with thrombolysis. or is there a question specific for doing mechanical thrombect involved?
No, no,
Or
it's, I
anything
think probably thrombolysis, just I think not
yeah, I think
mechanical,
medical
but
treatment invariably follows. Yes.
thank you. Dr. Rakhi had asked about scoring system. Dr. Kavit also had a similar question. I think we've talked about it. Dr. Rajesh Das has asked, is there a role of CT scoring in post-COVID fibrosis?
Not at all. Zero. So again, if you have a quantification software here, otherwise even don't even attempt with eyeballing. I have seen people giving percentage just by giving eyeballing, because if you just have to try yourself, just open your own scan that was reported 1 month back, and even if you reported even in the range of 5 to 10%, I would accept it. So it is so subjective and so difficult to give in a percentage. Even the score itself is difficult, but at least it has to be divided into 0 to 25, 25 to 50, that there will be some inter-observer agreement. But if you give just a random 30, 40% by eyeballing, even in the active COVID stage, I don't see any use, but in post-COVID-19, absolutely no use. In fact, it leads to confusion. So I have seen even on the follow-up, people give that there is a CORADS also, and people also give the scoring system also. Again, the score has no role. All you have to do is describe that whether, yes, the lesions are improving or worsening. So for that matter, if you say somebody with a score of 16 on a follow-up has a score of 18, it doesn't mean the patient has already become COVID-19 negative in all likelihood. It is the lesion, and if you know that there is something called as a reperfusion edema, even in lungs. So the whatever apparent progression that you see, or the lesion that have occurred in the interim, is actually due to reperfusion edema, which is even happening in COVID-19. And it doesn't mean progression. As long as the patient is doing clinically fine, it's just a radiological progression. And if you give a score which is increased, and again leads to all the unnecessary apprehension and treatment.
Correct. Thank you for answering that. Dr. Bishoy Samuel, I think you covered this. He had asked about diffuse bilateral cloud glass is considered atypical for COVID. I think he can go back to the start of the lecture where you talked about atypical and typical findings. Kiran Chauhan, Dr. Kiran Chauhan has an interesting question, but it's I'll go ahead with it. So he asks that a person with 10% and 25% will still be categorized as 2, whereas the severity is different. But I think that's how all scoring system works.
We have even given this particular example in our paper, that it is still that anything, it is still not a pinpoint. So that's why only if you have a quantitative software like Caliper is the time where you can actually use your own follow-up. And again, it has to be done on the same machine with the same software. Then only is the time where you can make this difference. And otherwise, everything will be the score, like every lobe involvement of 10% and every lobe involvement of 20%, both have a score of 10 with moderate involvement. And this is the exact example that we have mentioned in the paper, just to say that this is.
So that's what I said. I'll leave a link to all the resources that we discussed, and that paper especially has come out after years and years of experience. As you mentioned, some of the authors in that paper have tons of experience, and they know exactly what questions radiologists, say general radiologists, will have. So I will leave a link to all the resources that you discussed. Hopefully it's okay if we can take a few more questions, because there are a lot of questions, and this is a topic that it's a lot of people have issues right now. So Dr. Stuti has asked if there is any role of for imaging for post-COVID sequelae.
So yes, that's what I said. It should not be a blind follow-up or something that you just need to know what has happened to your lung lesion. So it is again driven clinically. If there is a not expected course that is followed up, or if there are new symptoms coming, or if there is an oxygen desaturation or the oxygen demand is not improving, that is the time. Or if there is a most common now is the super-added complication is suspected, that is the time, yes, the follow-up is indicated. Otherwise, no matter what your score was at the presentation, if you are improving, if you are discharged, if your COVID-19 has become negative, or your clinician is satisfied with your progress, then no matter, in fact, just by knowing your lung findings will only lead to problems. Like if you are completely fit and fine, but if I tell you your lung lesions are more or less same, what benefit does it give you? It rather leads to more apprehension and all the troubles. So that was the whole idea of not to doing CT scan. Even we know from the routine pneumonia that everybody realized the moment your fever, leukocytes are down, it's okay. But the moment you do how long it takes for the radiograph even to become normal. That opacity doesn't resolve just by clinical improvement. So that's the whole idea, that we are not treating the CT scan or the imaging. We are treating patients. That's what the whole idea.
Yeah. Correct. That's a very nice point that you raised, that we are going to treat the infection clinically and not the imaging. And a few months ago, there was irrational imaging. Even the general public, as you mentioned, was like more concerned with the CT scores and all that. Dr. Priya Jaiswal asked about subpleural fibrotic bands, and we've already answered that. Dr. Sunil Bonella, I'm sorry if I'm pronouncing it wrong. It's more of an anatomical question. He asks if the sella is involved, would you call it rhino-cerebral mucormycosis? I would not personally, like, it doesn't make a big difference, but what would you suggest?
I'm sorry, I was muted. Yeah, by definition, yes, it becomes rhino-cerebral. But yes, okay, you need to actually mention the most important findings, like just like I said in CORADS 6, the whole issue of calling CORADS 6 or CORADS 1, it is more better to describe what you are meaning. So yes, if there is a cellular involvement, you will mention there is a cellular involvement. That will give more idea rather than those terminologies. So those are our way of dividing the disease and categorizing it, but it need not be always followed the way it is completely.
Thank you. Dr. Ayush Jain asks, if a patient has peripheral consolidation with cavitation, would you call it pulmonary infarct or mucormycosis?
So cavitation is completely different. Like I showed, the infarct shows cavitation as a specific appearance. Especially, you need to not just see the lung window, you need to see the mediastinal window, where it will show those typical bubbly lucencies that I showed. And even a couple of other infarcts I can show where it shows similar findings. So that is the when you think of first as an infarct, and then you will do the pulmonary angiography to prove the thrombosis. But otherwise, if there is just a pure cavitation with just routine appearance, I mean, it is not due to COVID-19, then the super-related complication like tuberculosis or other mucormycosis comes into picture. And that's what we saw the different signs of.
And he also asks if we see lymphadenopathy in mucormycosis, no. The mediastinal lymphadenopathy.
Mediastinal lymphadenopathy has not been described as an association. So remember, even COVID-19 per se will also lead to some prominent lymph nodes, but not overt lymphadenopathy. But just like in interstitial lung disease everywhere, you need to be very careful about the short axis. So I have seen many lymph nodes even measuring 2 centimeters in long axis, but if the short axis will be still not be more than 1 centimeter. So in mediastinum, particularly the short axis dimension is very important. If it is not over a centimeter, and in case of subcarinal, even more than 1.5 centimeter, it's not the time. There can be a prominent reactive lymph nodes just due to COVID-19 or even in the other super-related complication.
Thank you. I'm not aware of this, but I don't know if you have any information about this. So Dr. Harsh Singh is asking about a white fungus. So is there something as a white fungus?
Now, yes. White fungus has started coming in. There are, I think he must be from Bihar or must be aware. Yes, in Bihar, in recent last 1 week, there has been a lot of cases of white fungus. And I can't pronounce that fungus particularly, but if you read, there is a different species. And it is said to be even more dangerous than black fungus, because black fungus follows more of a loco-regional spread, just what we discussed will be adjacent. It has more systemic manifestation. It leads to more of a pulmonary, even neural cerebral involvement, GI involvement. So yes, but so far it has not been so rampant, and at least in not this part of India that I am working in. So I have not seen a direct case, but yes, there is a white fungus also that is coming in big way. And if it grows out of proportion, then yes, the next webinar will have to cover white fungus.
And I think it's probably this black fungus and white fungus has got to do with the clinical appearance of the fungus.
Yes. That's
and then as radiologists, we just
snowflake fungus, if I'm not, because it leads to the whitish type of lesions rather than the black, because this is a necrosis here. That's the black. The white fungus manifestation are called snowflake. So that's why.
Okay, this is another question about doctor in the making, and even I have had it at some point of time. So he asks if we see hyperdensity and focus of air in the sinus without bony changes, do we call it fungal sinusitis or just hyperattenuating?
That is the shortcoming of CT scan, that we cannot judge the invasion part or the infarction part. till we see the other signs of CT, that is the bone invasion. So that's why I said the modality of choice is MRI. Even it may be difficult to see bony erosions on MRI, but the angio invasion and the necrosis that we see. So I think one of the example I forgot to highlight, that the patient had the one-sided fungal sinusitis while the other side was a plain sinusitis. You will invariably see the enhancement in the mucosa, which you will not see in the case of mucormycosis. So even before this overt signs of invasion, the non-enhancement part really helps you with MRI and the black turbinate sign. In CT scan, there has to be a bony involvement or any other sign of invasion surrounding soft tissue which has gone beyond the walls. That is the time which gives you the conclusive form of angio invasion. So before that, yes, the only way is to diagnose is with the MRI with contrast. So remember again, the plain MRI will be absolutely useless in those cases.
So you recommend post-contrast MR as the investigation of choice?
Is the investigation.
So Dr. RKG has asked about septal thickening and bands, which we already talked about. Dr. Sahil Kulkarni asks if there is resolution of findings in a follow-up scan shows consolidation and nodular consolidations. I think this is probably a very specific case that he came across. So would you call it possibility of super-added infection or fungal infection?
Yes, I think what you are trying to say, I think, is that the COVID-19 progression will not occur like that. So yes, that's what that was the time. If you have a consolidation progressing in a otherwise post-COVID patient, then yes, that the question will be super-added complication. And if there is a suspicion of mucormycosis, so remember mucormycosis in immunocomponent, I know I started reading some articles also, but practically it is not seen. So there is a immunosuppression, that is all, the patient will be immunosuppressed, known diabetes mellitus case, and on steroids or plus or minus depending on the cause of immunosuppression. That is the time when we will be suspecting. So in a immunocompetent patient, otherwise a post-COVID, just for that matter, will not be a mucormycosis and will be usually the other bacterial infection.
Thank you. Sai Krishna has asked about percentage of lung involvement. We've already talked about that, so maybe later you can go back and read about it. Dr. DBS has asked if there is a PCR positive COVID and PCR has turned negative, but chest changes are persistent. Should we give a CT severity or a CORADS score?
No, the moment that's where the COVID-19 sequelae word comes in. So either the patient has been discharged or the symptomatically resolved or the PCR become negative. That is the full stop for you to stop giving COVID-19. Of course, now there is one theoretical possibility of COVID-19 reinfection, and probably there are some cases also, but yeah, that is also not so commonly seen. So we will not get into that otherwise, but that will be, of course, the time when we have to again go into it. But otherwise, the moment the patient has been COVID-19 negative, that is the time the word COVID-19 sequelae comes in. And like I said, there might be a progression even post COVID-19, and that is something called as a reperfusion edema that is present.
Mm-hmm. Okay, I think fibrosis, and now because the disease has been it's been some time, so a lot of questions related to that. So Dr. Sahil Kulkarni also asks that if there is fibrosis or say reticular areas, would you include that in the CT score or only the ground glass areas?
CT score includes everything. So like I said, CT score will be given in the active cases or the patient with PCR positive or the not in the post-COVID-19 cases. So that is the time we have to take into account every lesion, whether it is a ground glass, whether it is a reticulation, because like I said, reticulation doesn't mean fibrosis or the resolving stage. It can be even reticulation bands are still present even in the first 10 days of many cases. So the whole idea of that temporal evolution, looking at the morphology, was initially when there was a cytokine storm suspected at day 10, where most of the patient used to deteriorate, go into sudden respiratory failure. That is the time where the lung lesions were to characterize to decide when will be, because not everybody has a clear-cut demarcation of symptomatology. So that was used to decide that, and that does help you, but not always. So you cannot rely completely on that.
Okay. I think that that answers his question. Dr. Zain Khera has asked, do we see pneumothorax or bronchopleural fistulas in COVID?
Fistula I have not seen any, but yes, pneumothorax is common. And again, the first and foremost would be if there is a mechanical ventilation, and even if there is something called as a proning therapy, which is very commonly done in this patient to improve the lung function. that can also lead to pneumothorax, pneumomediastinum and complications. So again, you need to know that. But just looking at it, again, it's something that you need to mention, because pneumothorax can add to the further desaturation, and whether there should be aspirated or not, or the tube should be put or not, might be decided after once you have pointed out that there is a pneumothorax. But otherwise, going into the etiology and the linking with COVID-19 is not something that is really important. Usually it is a complication of one of the management.
Correct. Dr. Shramona Bakchi asks if involvement of the pterygopalatine plate, is that the first sign of cerebral mucormycosis?
I don't think so, because it's not invariably present. So the cases that I showed, I don't think so the pterygoid plates were involved. It is just a loco-regional involvement. So I think if there is a sphenoid sinus, which is lead to more of the spread, then yes, the pterygoid plates might be involved. But where will be the question in case of the pathways from the anterior cranial fossa? From the frontal or ethmoid sinus, that can be a direct extension from the anterior cranial fossa rather than getting into. So that's why I said even that medial rectus, I have seen that common person. Actually, one of my junior pointed it out when he said that there is no mucus. It's not something like thyroid toxic ophthalmopathy where there is a inferior rectus is commonly involved. There is no predilection. So that's why I showed all the three examples. One with maxillary sinus involving the floor, and that's why inferior rectus. The other with ethmoid sinus with lamina preparation, medial rectus, and the last was frontal sinus with orbital roof going into the superior rectus. So it's just about the local invasion that the mucor follows.
Okay. So Shivanshu has asked how to differentiate inspissated secretions, but we've discussed that. MR would be the modality. So if you have a patient who matches that demographics, I think you should suggest a contrast MRI. Dr. Sneha Rathod has asked a very practical question. If a patient has ILD and COVID, unfortunately, how, like, do you score it, or how do you go about that?
So again, yes, it might be a challenge sometimes, especially not that couple of cases that I showed overt UIP pattern. So you know the honeycombing and fibrosis is not part of COVID-19. But yes, if there is a subtle ILD, especially with NSIP pattern, it might be really difficult. And that is the time where we actually even put it on our report saying that it is actually difficult to differentiate the two. But you try your best and to judge it depending on what you feel, especially the more the central the lesion, that you will definitely include your scoring. But yeah, the subpleural part will be a bit compromised. But again, like I said, by and large, breaking those barriers will only be the issue. So again, anything from 5 to 8 is not going to make any change in the management per se. Same way, going from 10 to 14 is not going to make that big a difference as long as the clinician reading the report is concerned.
We have a lot of questions. We'll try to take one last one maybe. Because most of them you have answered regarding follow-up and CT scoring. So when do you, so Dr. Rajesh Das has asked, when do we stop giving CT severity score? Is it just 14 days post-COVID, or when we have RT-PCR negative?
Yes, so but not everybody do RT-PCR and wait for it to come negative. So if the patient is hospitalized, he will be invariably getting a negative report before he is discharged. So that's one thing. But all the patients who are home quarantine did not do a RT-PCR if they are symptomatically doing good, then just by itself. So then that is the time when we follow that 14 days rule, that if the patient has resolved symptomatically, then that is also one of the things. After that, you should start calling everything as a COVID-19 sequelae. And once you are into COVID-19 sequelae, there is no role of scoring at all. In fact, it may, like I gave some example, that it may lead to confusion because there might be actually a progression while the disease has not progressed actually.
Okay, I think with that we'll stop because we've already exceeded and we've taken a lot of your time. Thank you, Dr. Parang, for patiently answering all the questions and for the excellent talk. I think if there was a one-stop lecture which somebody should refer to for COVID, I think this is the one, because not only you covered the basics, you showed excellent images, and you covered everything that a radiologist should be knowing in relation to COVID. So again, thank you. And you've got excellent responses. Even in the chat, everybody is kind of praising your presentation and your talk. So I thank you from the bottom of our heart, because this will definitely clear a lot of confusion and help general radiologists who are having tough time given so much of information in a very short period of time. So I think this would be really helpful. So thanks a ton for the talk.
Thank you. Thank you so much for having me, and thanks, Amar, for the invitation. And I really hope this was useful for everyone. And let's hope to see you soon.
Yes. I know that a few of the questions are not answered. I apologize for this, but most of them you've answered at some point during the talk. So make sure that you can go back and watch the chat again, watch the talk again. So most of them will be clarified. If there are more questions, make sure you leave them in the chat, and I will request Parang to answer them maybe sometime later. And thank you all for attending this. And before we leave, for those who are new here, make sure you hit the subscribe button and turn on notifications so that next time we are live, you'll get all updates. Just an update about our webinar next Sunday. So we're doing a COVID relief webinar. We're going to contribute to an organization called Doctors for You. We're going to have I'll just quickly share the page that we have created. And for whomsoever it is possible, I would request that you'll go to the link that I'll leave in the description and contribute as much as possible, because this is going for a noble cause. We'd like to thank Dr. Ayush Jain and Dr. Zia. Let me just check. So Dr. Zial Mustafa and Dr. Ayush Jain and an anonymous contributor have already contributed to us. And we'll see you guys. Even if you're not able to contribute to us, that's perfectly fine. I can understand. But make sure that you join us on Sunday, 10 a.m. for this marathon radiology teaching session. Thank you, everybody. And I shall see you guys in our next lecture. Bye-bye.